Hey folks, it's Beth Wright, and I am providing you a podcast of Chapter 32 for your NUR 236 pharmacology class. And this is about drug therapy for fluid volume excess. Basically, we're talking about our diuretics. And of course, diuretics are drugs that help remove sodium and water from the body. It also removes other things too, and it's very helpful, and my guess is you have probably administered diuretics in your clinical setting, probably several times, but it's helpful with patients with hypertension, heart failure, edema, ascites, renal failure, where increased extracellular fluid that causes adverse effects to the patient. So when we're monitoring the effectiveness of diuretics, what is it you got to assess, and what do you expect to see? We need to always assess blood pressure before administering. We need to look at the lab work for individuals, specifically the electrolytes. We need to be watching their weight. We need to be watching their kidney function. What's their intake and output? And what's their hydration status? So the diuretics we know will produce a lower blood pressure, and it will help decrease edema and weight loss and an increase in urine output. Those are things that we expect to see. And since the patient has an increase in urine output, we must be assessing for dehydration. And so thinking about what are signs and symptoms of dehydration, you know this, dry skin, dry mucosa, what's their skin turgor, what's their output. So we need to be watching about that, and we need to be thinking about what output would we be concerned about. Okay, I know we've had always talked about 30 mLs per hour is a minimal. I think the new rule of thumb is 1 milliliter per kilogram per hour is the new kind of hallmark urine output sign, so that's probably what we'll be using. So in the slide it has listed your objectives. I want you to remember that all test questions come from an exemplar or an objective. So be sure to look at your objectives. That's going to be crucial because again, that's where your test questions are coming from. So be sure to look at your objectives carefully and make sure you can answer those. These are your exemplars for this particular unit: hydrochlorothiazide, furosemide, bumetanide, spironolactone, mannitol, diazide, maxide, and aldactazide. So these are your exemplars that you need to be concerned about with this particular chapter. So let's talk just a second about renal works, because that's what we're dealing with here. These medicines work on the renal system, and so we know that the renal system helps regulate our volume and the composition and the pH of body fluids, and it's got, it does a lot of work. The kidneys are busy organs for sure in the body. And so, therefore, it must receive a lot of blood flow or cardiac output. 25% of cardiac output is devoted to the kidneys. The renal structure, when we think about the structure, your main functional unit of the kidney is the nephron, and that is composed of the glomerulus and tubules. And the functions are three processes. We have the glomerular filtration that happens where blood is being filtered in there, and Tubular reabsorption occurs with important things that we need back in the body, goes back in at this point, tubular reabsorption, and what we don't need in the body, and if you will, we'll call it waste, goes through the tubular secretion. So all the waste and bad stuff that needs to get out of the body does so through tubular secretion. And that all occurs with our glomerulus, or your nephron. Our daily minimum output is total in a 24-hour period should be 400 mLs or 30 mLs per hour. A new, again, standard is 1 milligram. That should be 1 milliliter. 1 milliliter per kilogram per hour. So many clinical conditions can affect the renal function, and when the renal function is affected, our whole body is going to be affected. And we can have excessive amounts of substances that can be retained, or we can have needed substances that should be retained are being eliminated. So there's can be an imbalance there for sure. And disorders that are where diuretics are being used to help manage those disorders would be cardiovascular, such as heart failure, renal, such as acute renal failure or chronic renal failure, hepatic, such as cirrhosis, where a patient might get ascites. So there's numerous conditions where you might see diuretics being used. So general characteristics of the drugs, diuretic drugs, they act on the kidneys to decrease reabsorption of sodium, chloride, water, and other substances, such as potassium. That's a biggie. That's one we're always concerned about. Major subclasses are your thiazides, loop diuretics, your potassium-sparing diuretics, and your osmotics. So the use of diuretics increases that renal secretion of water, sodium, and other electrolytes, and it increases urine formation and output. It's used to manage for edematous situations, heart failure, renal disease, hepatic disease. For non-edematous situations, it can be used for hypertension or ophthalmic surgeries. With edema, it helps mobilize tissue fluid by decreasing the plasma, and with heart failure, it helps get rid of that fluid that's been accumulating, and with the hypertension, it stops that the sodium depletion is what helps with controlling the blood pressure. Okay, so let's take a look at this particular slide. I'm probably going to spend more time on this slide than any other slide that you have. So let's go through each one of them. Your thiazides, and for your exemplar, that's going to be your hydrochlorothiazide. And so you can read there on the different things that, for the thiazides, that decrease reabsorption of sodium and water, chloride, bicarb, and potassium. We do have potassium loss with thiazides. Thiazides aren't as effective as your loop diuretics in an acute situation. Your loop diuretics, that's what's going to be used in an acute situation. It is ineffective if the GFR is, your glomerular filtrate rate is less than 30. It starts working within 2 hours and peaks around 4 to 6 hours and lasts anywhere from 6 to 24 hours. And precautions for this are allergies to sulfa drugs, and pregnancy is also a precaution. So if you look at the generic names of other thiazides other than hydrochlorothiazide, you'll see that it has thiazide at the end of it. It causes a moderate loss of sodium and water via the kidneys, as well as loss of potassium and chloride. Now, the loss of potassium and chloride can lead to metabolic alkalosis if the patient loses too much. So we gotta keep a watch on that. Some patients may need to have a potassium supplement, as you'll also see with loop diuretics. The thiazides are also known to elevate the glucose level, the blood glucose level, and blood uric acid level. So they need to be watching about that, especially if it's someone for glucose. If they're a diabetic, then they may need their medications adjusted for that increase in their glucose if they're on thiazides. With uric acid, that's what we see with folks with gouty arthritis, so we might be watching for signs and symptoms of gout. And, usually for some reason, the great toe is a common place for gout to occur, but it can occur in any joint area, but that is a prominent place for it to appear. So we need to be watching for any kind of signs and symptoms of that, and of course treat that. Also got to watch for hypersensitivity reactions. And one thing with diuretics, they should be given early in the day to avoid nocturia or nighttime urination because of the risk for falls between being tired and feeling an urgency to void. If you've ever been with a patient who takes diuretics, they will let you know when they gotta go, they gotta go. And it really pushes the kidneys and works on the kidneys, and gives them a sense of urgency that they got to go. Also, recall about your cardiovascular unit. Patients who are on digoxin and use a thiazide diuretic or loop diuretic for that matter as well, we got to be sure that their potassium level does not fall too low because dig uses potassium to do its job, and if it falls too low, then we can become dig toxic because the dig is going to be floating around there because it doesn't have the potassium to piggyback on to get to its place of work. So we got to be sure to watch for your thiazide and your loop diuretics. Watch that potassium for patients who are on dig. Also, lowering the sodium level for patients who are on lithium can cause lithium toxicity. So lithium, we got to be watching those patients as who are taking lithium and thiazide diuretics. Obviously, we got to monitor the INO and the vital signs, the daily weights, renal function, your labs. Make sure we're not getting in an imbalance in our electrolytes. Also, thiazide diuretics and loop diuretics can cause hypotension, and if it's combined with other substances that can cause hypotension, then that's going to be an additive effect. So the patient should be taught to avoid anything that can lower the blood pressure, such as alcohol or any other substance that could lower the blood pressure. So we need to teach about, changing positions slowly, that kind of thing. All right, loop diuretics. So loop diuretics inhibit sodium chloride resorption and it's volume depleting. And we definitely will have a potassium loss with this. It is more potent and has a rapid effect. The IV onset is 5 minutes and peaks at 30. And we give it over a 1 to 2 minute period. So we don't, ram it in there. We push it slow. The onset for PO is 30 to 60 minutes, and the peak is 1 to 2 hours. And the good thing about that is you can give it with renal impaired patients. And again, these are more potent than the thiazide diuretics, and they are for volume depletion. So again, if we know we're gonna deplete that volume, then we got to see about where that volume is before we give it. And so that's why we want to check that blood pressure before. Your blood pressure is your volume, and or your volume of your blood and fluid maintains that blood pressure. And so we got to see where our baseline is first. You don't want to give a medicine if you go in and a patient's hypotensive. Because they're going to become more hypotensive. So we got to be watching about that for sure. We also have to watch about greater sodium and water and potassium loss with this. So we got to watch the labs. We got to watch about the digoxin and lithium toxicity. Avoid that night administration again because they could potentially fall. Also, watch about the glucose level because that can occur with that, as well as the uric acid. And again, the medicine can be used for patients with a low GFR or renal insufficiency. So that's a good thing. Another thing with the loop diuretics is they can cause ototoxicity, meaning hearing loss. So especially if they're given in a high dose, or if they're given too fast, or with other agents that can cause ototoxicity, such as aminoglycoside antibiotics. Of course, furosemide is our drug for this in one of our exemplars there, and it comes in concentrations of 10 milligrams per milliliter. You don't have to dilute it when you give it IV, and it should not be given rapid. It needs to be pushed over 1 to 2 minute per period. It can also be given in a drip, IV drip. Another loop diuretic that is one of your exemplars is your bumetanide. So sometimes you may hear patients say that they're allergic to furosemide because it makes them go to the bathroom a lot, but we got to teach them that this is an expected effect of the potassium, and that's something we desire. We want them to go to the bathroom a lot, so we got to sometimes do teaching about that. Your next one is potassium sparing. So think of that name, potassium sparing. That means we spare the potassium, we keep it. So these diuretics are weak as diuretics, but are used in combination with diuretics that may cause the potassium loss in an effort to limit the amount of potassium that is lost. So these types of diuretics, and your exemplar for this one is your spironolactone. These diuretics, they have a weaker diuretic effect, but the other part of it is they don't cause us to lose the potassium. Okay, so if that being the case, if it causes us not to lose potassium, then that means we got to watch for reabsorbing too much potassium. So we got to be sure hyperkalemia doesn't occur. We got to teach the patient to avoid the use of salt substitutes because most of them are potassium chloride, and we got to be careful about any kind of potassium supplements being ordered. Make sure that they're not being given with a potassium sparing diuretic. Let's see. Also, aspirin or salicylates taken with aldactone or spironolactone can cause a decrease in the diuretic effect. and specifically a decrease in the sodium and chloride excretion. All of the potassium-sparing diuretics have been combined with aldactazide to create diuretics to decrease a loss of that potassium. So you may see where instead of the pharmacy in the hospital setting buying that actual drug, they will go ahead and send the spirolactone and the thiazide diuretic. So just be mindful of that, and don't forget to give both of those medicines. So when you see these spirolactones and the combination of a thiazide, you'll see ZIDE at the end of them. And you have 3 of these listed as your exemplar: aldactazide, diazide, and maxazide. Okay? And then last but not least is our osmotic diuretics. And these are used, the osmotic diuretics is mannitol is our exemplar for that. And this can be used for like acute renal failure, but where you see it used a lot is with head injuries where there's some kind of cerebral edema going on, and so they're trying to control the volume at that point. So it does cause a rapid diuresis and increases the osmotic pressure in the glomerulus. It pulls water from that extravascular space into the bloodstream and increases that blood volume. This decreases reabsorption of water and electrolytes. So it's pretty rapid onset for this, and you only give it IV. So here's a pictogram. This is what I call these things, a pictogram. It just shows you, it's called a diuretic water slide. It's pretty nifty there. It shows you about the nephron and the loop of Henle, where the medicines work, things to watch for, so you all can look through those. And then bumetanide is one of your loop diuretics, and so you can read about that. And then you have one on the spironolactone that you can read about that. That's what your potassium sparing. And then you have one on your osmotic diuretic, osmotrol, that you can read about as well. So I love the pictograms. So a little question for you here. Edema only occurs only when the heart no longer functions efficiently. True or false? Okay, the answer is false, because edema is the excessive accumulation of fluid in the body tissue, and it's a symptom of many different diseases. It's not just of the heart. Okay, so principles of therapy. Drug selection and dosing is going to depend on what's going on with the patient. You know, if it's a head injury, it's probably going to be mannitol. If it's heart, you know, and it's an acute situation, it's probably going to be a loop diuretic. Okay, another question for you. Diuretics are medication that increase urine formation and output. Da, 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 da. Okay, and the answer is true. Diuretics are medications that increase renal excretion of water, sodium, and other electrolytes, thereby increasing urine formation and output. Okay, prevention and management of potassium imbalances. So I've been talking about that, that we lose potassium. So obviously with diuretics, if we lose potassium, we've got to be concerned about hypokalemia. So you definitely need to know your labs on this. And Ways to prevent it is to start with the lowest dose of diuretic as possible and use supplemental potassium. You got to monitor for signs and symptoms of hypokalemia and monitor those labs. Increase food intake of potassium, so teaching the patient about that's going to be important, and to restrict sodium. And so I've got you an ECG. It's kind of blurry, but you can see what an ECG was. Talks about cardiotoxic. So we look at the T waves for potassium, and you can see that the T wave is depressed. So hypo, down, T wave, down, okay? So if you see a depressed T wave, you might want to look at your labs to see if you've got a hypokalemia going on. Okay, the other concern is going to be with hyperkalemia, and it again is cardiotoxic, and we want to prevent that as much as possible. We got to be careful with our potassium sparing diuretics and supplements, so be careful to watch for that. Avoid any kind of supplements, potassium supplements and salt substitutes, and maintain a urine output. Anytime we're doing something with the potassium, we've got to be sure our output is what it needs to be. 1 milliliter per kilogram per hour. And this is what might look, what your ECG might look like for hyperkalemia. So you can see the T wave is elevated. So hyper is increase, and we got an increase in that T wave there. Okay, so our nursing process for diuretics. We need the baseline vitals and a pulse ox. We got to assess for hypoxemia and cyanosis and dyspnea and fatigue. We've got to ask the question, if they've been on diuretics, why are they getting them? Serum electrolytes we got to look at. We got to look at our labs for renal, creatinine, BUN, uric acid. We should throw in there our GFR for our renal as well. Our uric acid, we want to do that blood sugar as well, since that's an issue with some of your diuretics also. We want to look at the urinalysis and look at the weight and intake and output. Edema, is it pitting? Is it non-pitting? If it's pitting, is it 1 plus, 2 plus, 3 plus, 4 plus? We want to do lung sounds and breath sounds and listen for congestion. What, if are they having sputum production? Are they coughing? What's the color of it? Frothy blood tint sputum is your hallmark sign for pulmonary edema, which often occurs with your heart failure patients. And these folks can get into trouble really, really quick. So we want to move on that. Is there GI congestion, gastrointestinal? Do we have nausea, vomiting? Is there ascites present? Do we have liver congestion, patient experiencing abdominal pain and tenderness on that right upper quad area? Cerebral edema, are we seeing any signs of that, such as confusion, headaches, dizziness, convulsions? What's their level of consciousness? Bradycardia? Are they non-responsive pupils? Those kinds of things. We need to look at the past medical history and medication list as well. And you see the list of nursing diagnoses is there. We can have excess fluid volume due to some part of the disorder, medical disorder. We can have deficient fluid volume because of the diuretics. We can have imbalanced nutrition because they're losing too much potassium and not supplying it back in their diet. Risk for injury could be because of the medication, because of the fall that they had where their blood pressure dropped. We can have risk for skin impairment due to edema or due to dehydration. if, we give too much of the diuretic. And, of course, we can have knowledge deficit. Planning is going to be safe administration of the medication and a decreasing of the edema, and that they understand the dietary requirements and there's no injury, and that they follow up with their practitioner. Interventions, we want to assess for those allergies and administer the meds safe. We've got to observe for therapeutic effects. We need to teach also about edema management, and that's on page 606. We need to monitor for fluid overload and diet interventions to help lower the sodium. Also diet interventions to help increase the potassium if it's indicated. Watch for drug-drug interactions, the intake and out, monitor labs, monitor the heart, lungs, skin, kidneys. And teaching is on page 598, so be sure to take a look at that. And the evaluation, we're going to evaluate, do we have a decrease in the weight, decrease in the edema, no injury, decrease in the blood pressure, no skin issues, urine output's appropriate, and the client is compliant with their medication, which is what we always like to see. Okay, this concludes your podcast for this unit, for this chapter.